Welcome to the Natasha Helfer Podcast. To help keep this podcast going, please consider donating at natashahelfer.com and share this episode. You can find Natasha on Facebook at Natasha Helfer, LCMFT, CSTS, and at Natasha Helfer MFT on Instagram and TikTok. You can find all her cool resources at natashahelfer.com. The intro and outro music for this episode is by Otter Creek. This podcast was edited by Ashley Piccini.
Hello, everybody. I'm Natasha Helfer. I'm a relational sex therapist. This is my podcast where we try to attack shame and get healthier through education, stories, relationships. I am thrilled to have Dr. Lisa Hansen with me today. We're going to talk about a really relevant topic, an important topic. There's just so much information and media and politics and laws and legislation kind of happening right now that is affecting our trans community members around the country. And I feel like there's a bit of a frenzy going on that is having some real, day-to-day life effects for so many people. And unfortunately, with a lot of misinformation and discrimination and fear and, just a lot of things. So with us today is an expert in the field, and Dr. Hansen has a practice here in Provo, Utah. It's called Flourish, and it specifically is a clinic that targets LGBTQ plus folks, and they work with tons of youth and their families on all kinds of issues. But today we're going to focus primarily on trans youth. And so welcome, Lisa, to the program. So excited to have you.
I'm so happy to be here, Natasha. You're discussing such good things.
Oh, thank you. We have collaborated on many things throughout the years, and have always just learned so much from you and just really enjoyed our collegiate,
collaboration.
So, there you go. Well, why don't you kind of just spend a few minutes just telling us more about yourself and where you come from and why this kind of topic kind of became so important in your life and your profession?
That's a good question. I always wonder why, because it isn't that anyone in my life brought this topic to me. But I think I've always been aware that the major questions in life for me are, who are the people that should be at the center of decision making, and who should be at the center of our care and concern? And I am going to talk religion just a little bit, because even though this is a professional podcast and in the therapy room, we don't bring religion in unless a client brings it too. I think what we're dealing with and the big pushback that the culture wars, as we call them, are having is primarily religion fueled. That is, there's a religious sense that a good society looks like this. And for me, the good society looks like the people who are impacted are in the chairs making decisions. So I started with that as a young person growing up in the civil rights years in Indianapolis. And that gave me a strong sense of how religion could be used to push people away from the seats of power. And that was what a good society was keeping people in their place, so that those who had more spiritual mindedness or more holy in some way could make decisions about other people. Just want you to know that is where I come from. I went back to school to get my master's degree and doctorate degree from BYU. My main ideas were I wanted to help lift the LGBTQ community, to sit in the seats where decisions are made, to no longer be oppressed by straight cisgender people. That is where I come from. That's what got me started in this. When I finished my master's program, I started work immediately. Most of my clients were in the LGBTQ community, and I started working at Encircle as Encircle asked me to start the therapy program. That's how Flourish began. And then when they wanted to do their own program, Flourish went off on our own and started flying. We have 36 therapists, 2 nurse practitioners, and we do between 300 and 500 free sessions of therapy every month out of our 12 or 1,300 sessions for the LGBTQ community. We do mostly teletherapy, although we are in Utah County and Salt Lake County in brick and mortar building.
Yeah, so it comes kind of just out of a sense of justice for minorities, it sounds like, and in particular, this particular population just really kind of, it sounds like, tugged at your heartstrings and kind of became important to you. So, and just became involved. Okay. So can you give us a sense a little bit of the lay of the current land? So currently here in Utah anyway, we had some legislature that was signed in January that had an impact on the types of medical treatment that in particular minors would be able to receive. Are you able to give us some education on what that means and what that's about? And I think it's similar to several other states.
Many states have passed some kind of transgender medical health ban.
And is this primarily
for
minors, like under the age of 18? Is it for also adults? Like, can you just kind of give us a sense of what's happening?
While other states are passing or attempting to pass legislation that bans medical care for adults, people 18 and older, the SB 16 here in Utah that was passed and signed by Governor Cox is about those who are younger than 18, who are not entitled to medical care for gender affirming medical care if they have a gender dysphoria, which is a medical condition. However, they are allowed gender affirming medical care if they have precocious puberty, are intersex, have some sort of menstrual disorder, for example, or any other number of things that don't seem to the legislative world, because that's where it really is going to count, to be needing medical care. And I just want to start by debunking a myth. When people start talking to me about this, the first thing they say is kids getting surgeries, young girls getting their breast cut off. This is like horrifying. This is like torture. This is like, how can a young person even know what's going on? First of all, whoa. The medical care that most of our young people are going to need is not surgery. There's only a teeny tiny percentage of our young people who have been diagnosed with gender dysphoria who will have a surgery before they're 18 years old. And it's usually someone who is an athlete who has to wear a binder for extra large breasts and who does not want to be female. And so they wear a binder, and it's already a medical problem because they are experiencing constriction, problems with skin, problems with underlying muscle tissue. Those are the ones who are already having a medical condition. So let's just get out of the realm of our babies are having surgery, because that's not what we're really looking at. I just sort of threw that in as a beginning.
Yeah, so one of the misinformation out there is that people are kind of changing their bodies in ways that cannot be changed back before the age of adulthood. Is that fair?
Right. When actually, 1 out of every 1,000 babies already is having something done to it without their permission, because the parents get to decide. We know that 1 out of every 100 babies, you look at it and there's something, when it's born, there's something that is, well, that's not 100% male or female. We've got something going on. But 1 out of 1,000 has to get some kind of surgery, and the parents have to decide what surgery that is. I like to compare it to, if you go to a football stadium, you got 60,000 people there, and 1 out of every 1,000 has had that kind of surgery. You got a whole section of 60 people. We're not talking about, this is like, we've got people who are already receiving surgery for gender affirming care without their permission. So now we're not even letting people who have an idea about something weigh in on it.
If we want to get a little bit more general, if you count circumcision as something that's happening to a penis, that's happening to one in two. As far as something that's, you can't get that back, and we're making those decisions without any consent. So
no, and that's not even gender affirming. There's no disorder that it starts with. It's
there's no disorder.
I'd like to do this to my child.
But we digress. Okay.
Actually, I think it's really relevant.
Yeah.
Glad you brought that up.
Yeah, no, I think that it's so interesting to see the cognitive dissonance, right? Like the hypocrisy on so many of these things where people are so comfortable with certain things that are just culturally accepted, that are so interesting. And there have been cases where circumcisions have caused tremendous complications.
Damage.
And if they are a small percentage, it still has caused tremendous complications for people's entire lives. And yet it is something that we just kind of take for granted it's going to happen to
routinely.
To a baby that's assigned male at birth, right? So let's go into kind of the next, I think, fear that people have, because, well, you wrote an excellent op-ed in the Salt Lake Tribune, which is a big part of why we're having this interview. So maybe let me just ask the question, like, what is the big hoopla? Why are legislations getting involved? Why are we, all of us, instead of keeping this in the medical and mental health field, right? Why? I mean, we don't have legislation saying, no, you cannot do this kind of cancer treatment. No, you cannot do this kind of, diabetes treatment. I mean, I guess there is an FDA approval, that is part of the government, but we don't really have like as many regulations and things when it comes to legislation around medical issues. Why has this become such a cultural issue, and what's driving it, and what are some of the points that you just kind of want to start? Like, what's all the hubbub about?
Hubbub is about how we feel about gender in general. And most of us grew up with very deep and, for the most part, unexamined feelings about gender, but really strong ones, so that we likely had preferences about this or that, or certainties about who could do this or who could do that as we were growing up, or what a female person is more likely to do or be or represent or move into, or what a male person is. I like to ask people to examine this by saying, so when you're out in the world and you're at a service desk, or you have a waiter person come up, or you are on an airline flight, if you're able to do that, and you have a person who's helping you, does it make a difference to you if that person seems to be your sense of male or female? Here's the exercise. Imagine that person is actually a different gender than the one, they look the same, but imagine that they're a different gender. How would that make you feel differently about them? How would you treat them differently? How would you respond to them differently? Are you warmer towards one gender than another? Are you more logical with one gender than another? Do you feel more paternal, even at whatever gender you are, towards someone of a certain gender? Do you feel more intimidated? What feelings or ideas do you have that are in there deep about gender? We have them. I remember the first time I went to campus with my dad. And of course, my dad was on the same campus in the 40s. And he walked around campus with me and he said, this is in the 70s, by the way, he said, Lisa, I can't tell the men from the women these days. Why? Because for the first time, women were wearing pants on campus. And that totally upset his sense of what should be happening here. And it affected him viscerally. He had a really difficult time interacting with people because they were not behaving in an expected gendered way. Now, let's tell you a secret about my dad. He treated men and women he didn't know very differently from one another in categories. I'm sure I grew up doing the same thing. It is in us deep. Even people who say, oh, I treat everyone the same.
Yeah.
We don't. So this is what is inside of us, is this sense of our awareness of how life should be is now disrupted. And it's not just social, it's moral, because this binariness was given us by the divine being who started our world, and we're disrupting that. And now look at what's happening. That's the short story, I think, of why people are so upset.
Right. So it really disrupts our own sense of comfort, our own worldview, our own ideas of what is right or wrong, even morally right or wrong. And we even see this, like I even see this kind of in the feminist movement, right? That there's this idea that if you're a real feminist, it's imposing on us as real women to have trans women, to be accepting of trans women. So because, we were oppressed, vagina owners were oppressed. And if you have, somebody who was born with a penis, but now wants to join our camp, that's not, you weren't truly oppressed because I guess you weren't born with a vagina. Is that, you see, I mean, this is kind of
I have seen that. Yeah, I certainly have seen that feeling. People who are oppressed, unfortunately, often tend to start fighting at who's got the greater pain, when actually we can all support one another.
Right. It's like, why do we have to do that? Okay, so this I think you hit on like personal discomfort. And then I think another thing that happens that I see a lot is then people go to, I'm going to protect my children. I don't want my children to learn this at school. I don't want my children to associate with people who could influence them. I hear a lot of this whole, oh no, this is now a pandemic. We're seeing more and more numbers. I even see this kind of coming from physicians or other mental health counselors who I don't believe are as well informed. Like, I guess if somebody has gender dysphoria, now my child is going to have gender dysphoria. They're in danger, at risk at that. Can you speak kind of to that fear, that panic of parents, and therefore they're trying to stop the influence of this kind of, I don't know.
Yeah, if we can just keep them from breathing the fumes, then we can keep the toxicity from moving into the classroom. And the reason I use that is because, of course, the classic social contagion or the hysteria example was a school classroom where one of the students sitting next to the ventilator started to say, I'm breathing some fumes from something that's coming through the air system. And they started to have symptoms of dizziness and difficulty breathing. So everybody's concerned about it. And then the rest of the people in the classroom started having some of the same symptoms. Well, as it turned out, there's nothing. As they tested it, they were very concerned. You can imagine in a school. They worked really hard to make sure, and there was nothing in any of that air. But when one person experienced it, other people started saying, do I feel the same thing? And it started happening. So this is what we recognize is the truth about social contagion. When actually you are observing something, you have a chance to see it, you have a chance to see someone else experiencing it, there's something in us that says, that me too. We've all gone through this when we studied abnormal psychology, yeah? Am I OCD? Am I borderline? Do I have schizophrenic personality disorder? I mean, these are things that, and medical students, this is what they do too. Do I have this rare disease? And I have a sister-in-law who, when she was studying and they were just talking about this rare thing, they each took a little study. She had it. So one never knows, when you are thinking about something, that something might come up. But the point is, it's also social contagion to be afraid of this. To be afraid of the reality. One mom's afraid, then another mom's afraid, instead of saying, this is really interesting. This is where I want to bring my sense of God into this, even though I would never do this in the therapy room. I do think God is sending us gender expansive children. Children who are willing to say, hey, your old ideas about what it means to have a vagina or a penis or something in between, they're not very helpful to people. They limit people. Your ideas, your deeply held ideas actually limit the people you interact with. And wherever you have a position of power, you end up limiting the people who do not share that power with you because of your ideas about sex and gender. So what question was I answering?
Yeah, kind of this fear of a pandemic, right? So
Yeah.
you're doing kind of an interesting kind of exercise. Are we not already in a pandemic of discrimination against this? And as we,
Exactly.
right.
Mhm,
So as we
mhm,
expand, and
mhm.
I mean,
And
I
let
think
me,
even your example of your father on a campus,
mhm,
where men, and remember, the hippie movement, right? Like the generation prior had a fit, rock and roll music and men with long hair and
and I
men with,
love it when people talk about cancel culture like it's something new, like gay people or gender queer people haven't always been canceled from the very beginning. Any whiff of it, you're not included. Any whiff of being less than what we consider to be adequately male or female, we don't want you on the team. You don't get to actually participate. We think of you as sort of a perpetual adolescent, never having fully developed. So cancel culture has existed ever since the beginning. We are now just beginning to say, hey, we would like to cancel people who are not making room. That's what I look at it. And I'm kind of grateful that we take a look at that and say, hey, if you're not making room, you may actually be part of the ongoing problem. Anyway, so to me, yes, the pandemic has already been here limiting people. Now, let me say this. I do believe that young people are going through a period of saying, what is true about me and gender? What is our culture telling me? And maybe I don't want what the culture is telling me about gender. And so I'm going to actually take a stand on something that is deep inside of me, which is why we find that young people who identify as non-binary or transgender are actually less likely to be people pleasers. So there is something social about this. But as we all know, the secret is not to say, hey, we're not going to let you look at this or think about this or pay attention to this. We're going to make sure you don't get any information about this. Never worked. Never worked. My
right.
dad told my brother, you take that Hard Day's Night album and you destroy it. Didn't work.
It didn't
Brother
work.
was a rock and roll fanatic forever. And of course, we're talking about much deeper issues of identity. And when
Right.
people recognize something about identity within themselves, super important to pay attention to that. We know that 70% of children who are gender dysphoric, gender nonconforming, will eventually become comfortable with their bodies. So it makes sense not to run out and say, hey, we have something we can do for you. Never a good idea. It's never a good idea for parents or medical people to label children, to wait until children tell you about themselves. Recently in the news, there was a professor at BYU who discussed her child's diagnosis of gender dysphoria with the classroom. It was actually one of the class members who took offense at this, who reported that the teacher had talked about her transgender child. There's nothing in the student's story that said that the professor labeled their child as transgender. Professor talked about the diagnosis, but it was the student who was offended who labeled the child transgender. And then it gets out in the media that the professor did this thing. Labeling is a huge, huge problem that we should leave to the people who are experiencing it, not to anyone else.
So this kind of goes back to these fears, right? That mental health professionals are immediately pushing, or labeling children to, identify a certain way, to start hormone replacement therapies. Obviously, there are lots of teens who do choose hormone replacement therapies. There's lots of parents who support that. Can you talk a little bit about what that process is like? How does it, a child who maybe starts thinking about gender dysphoria or, has gender dysphoria, maybe at a young age or maybe at 12. Some of this starts as young as 3 or 4. Sometimes these things start at 12, 11. Sometimes these things start at 22, 25. You know, I mean, like, can you give us some different ideas about some of the cases and what they might look like?
Sure. And let's parse out the word lots, because there are certainly more now than ever before. There have been a lot of reasons given for the Tavistock clinic closing in Europe. One person reported they were just giving out hormones so readily that it just, was unsafe. The official reason given was, of course, something quite different. And actually, England intends to open a number of gender clinics. The one clinic got completely overwhelmed. And that's because there are more cases of gender dysphoria now than there ever have been. I think it's really important we take a look at why, and we take a look at what expansiveness is. When we say lots of children are on hormones, I want to say most of our young people with gender non-conforming issues will not take puberty blockers, will not go on to take gender-affirming hormones. It is a common experience to wonder about gender, especially if one doesn't fit some Hollywood ideal of masculinity or femininity. To say, what is wrong with me is like the quintessential question of young adult, of youthhood from the age of 12 to 21. This is what diaries and journals are full of. What is wrong with me? Why don't I fit what it is I feel inside? What is it that doesn't match? This is identity development. This is the perfect time for young people to be saying, what about me is really female? What about me is really male? What does that mean? What does that mean in terms of my body parts that are developing? What does that mean in terms of the roles that I want to have? What does that mean in terms of my interactions with other people, how I'm responded to, what my future hopes are, what my mentors offer? All of those questions are essential. And when we say to a 13-year-old, don't want you exposed to any of this, what we're saying is, when you're 23, you can start your identity development. Let me tell you, this does not go well. That means a young person has lost all these years of really thinking about their identity and asking these questions. That's what we want, is deep asking, so that a person at 13 or 14 can say, Mom, I'm not a girl. And then at 15 or 16 can say, can I wear a dress to prom? Because I'd like to try that. And then maybe come back and say, I'm never going to do that again. Or that brought something else out in me. We want them to feel open to their experience, not cut it off, lop it off, and then not have any idea, because we have way too many people in their 30s, 40s, and 50s saying, I wish I'd been able to explore this when I was 14, 15, or 16. And now they have children, grandchildren.
I love this. Yeah, I love that you're explaining this normal developmental fluidity and flux. We want things like explained, like, and I've seen people that are like, okay, well, even affirming parents who are like, okay, they told me they wanted to be a girl, but then 2 years later they wanted to be a boy, or they were non-binary, or they're this, and they can't make up their minds. Quote,
We're
unquote,
on our sixth
can't make
inning.
up their minds. And we kind of, I think we're not taught as parents that this is actually a normal part of human development, that we don't have to make up our minds.
It can be. But most of us as parents did not have any of this in our childhoods. There was no discussion, there was no openness, so we're afraid of it. And when this child was either born to us or brought to us, or we reached out and brought this child to us and brought it into our home, we once again had these really strong ideas of what the sex or gender of that child meant to us. And it had a future that went this way or that way, or up or down, or we imagined a particular gendered kind of relationship, or we imagined a gendered future of this sort or that sort. And that's in there so deep that when a child says, actually, if you're going to have a relationship with me, this is me, a parent has to actually grieve for the death and loss of that child that they had in their mind. This is how deep it goes. A parent can actually have a personal shrine, whether it's real or not, to the child they thought they would have, while their real child is living a life that the child loves or the child is committed to out over here. This is where we are. And our parents didn't have to go through this. So we are pioneers. We've never had to do this. We are brave. We are strong. We are dealing with these griefs that our parents didn't have to deal with.
Right. So this is probably something that's interesting for people to hear, is when you say most teens who go in for gender affirming care are actually not on puberty blockers or even on hormone replacement therapies. When do those decisions start to be made? When does it become necessary for those kinds of medical treatments to be deemed necessary?
Depends on the distress. In other words, if someone comes in cheerfully and says, I think I'd like to try this, feels like a really good step for me, we have to start with a healthy skepticism. We have to start with, there's a lot to know about what we don't know. We do know that puberty blockers are not approved by the FDA for gender dysphoria. But here's the secret. They are approved for precocious puberty. So if you have gender dysphoria, are they safe? They would be safe if it was precocious puberty. That's not really your question. Your question is when. So when a young person is deeply in distress, then when we begin to examine that, what is the distress coming from? Is it coming from a comorbid condition? Are they feeling just general rejection at school? And this feels like this could actually make me more popular if I were fill in the blank. Does it come from a sense? We had a family who brought a Chinese adoptee who said, I think she had a sense that women were not valued in her culture, and that's why she wants to identify as a boy. There's a wide variety of reasons. We've had young people who were sexually assaulted, and after the assault said, I do not ever want to be seen as female again. We understand that some issues such as wearing baggy clothing and appearing non-binary, or not wanting anyone to see our female body parts, is directly connected to a sexual assault. So there are many things that need to be looked at. What is going on for this person? And if there seems to not be a clear experience of gender dysphoria, there doesn't seem to be something that says my distress is about this gendered issue of my body and what my body is doing and how it is developing, which is why puberty is the place where a lot of this happens. Parents are calling this late onset dysphoria as opposed to a 3 or 4 or 5-year-old who is certain from the beginning. But often kids just try to conform until puberty happens and then the distress hits. I don't see this so much as late onset as I do been people pleasing for a long time and trying to perform my life the way so many kids do. And then they're in deep distress. So they come in and maybe what they need is just an exploration of their experiences and what things mean to them and what their past means and what their future means, what their interactions with other people mean. But if a young person comes in and is absolutely certain, challenging that certainty is not going to help. Exploring it with them, with what we call affirming, which is not, I'm out ahead of you. It is, I'm not going to challenge you. I'm actually going to explore it with you. And I want to make sure that you know everything before you leap in, so that 5, 10 years from now, you don't say to me, why didn't you talk to me about this? So we'll talk about reproductive impact. We'll talk about bone density impact. We'll talk about that whatever kind of decision you make about this may not bring you the social rewards that you're anticipating, depending on who you're trying to get them from. So we'll talk about those things. And for some people, that's enough, is talking about them. For others, what they clearly need is some way to stop these breasts from developing, or stop their voice from deepening, stop hair from growing on their faces, stop the chin from widening, to actually address what it is that is in their minds and hearts about who they are. One of the most interesting things, Natasha, is to discover that there are places in the brain that are more similar in women and transgender women, that is, whose other body parts may appear male, or whose chromosomal makeup may include some male chromosomes. But there are parts of their brain that actually are more female-like. And we recognize that a sense of gender is likely in the brain. So we should look there. What is happening in the brain that tells someone who I am? If it fits for you, that your body and your mind are the same, wonderful. But to decide that it should be that way for others and there's something wrong with their brain we need to fix, who are you to make that decision?
So when we're looking at gender affirming care and people who are doing this type of work and who are trained to do this type of work, this is the therapy, right? This is this is what the clinics are doing, and these are the conversations, and these are the conversations that are happening with kids and with teens and with parents, and it's very thoughtful and intentional, and as you're saying, affirming. And then when you get to the point where maybe the decision is, okay, let's move forward with hormone therapy, with puberty blockers. So you mentioned in the Salt Lake Tribune article that the Journal of Pediatrics, that hormone therapy for teens results in 73% lower odds of suicidality and 60% lower odds of depression compared to those who are not taking those kinds of interventions. And those results are supported by, of course, other studies. And you also kind of made an interesting kind of comparison that a lot of schools and a lot of, other types of spaces where, suicide amongst teens is something we're all concerned about for all kinds of teens. And sometimes we spend tons of money on programs and we're super happy if we get like 5% lowering, right, in the numbers. And yet here is something that in a particular population, we have huge levels of decrease. So is that something you can speak to, is that, this distress that you're talking about, it's not minimal distress. It's not like, oh, I'm just, sometimes the word distress, I don't know that people understand how we are talking about that word in a clinical way.
Yeah. Thank you for that. And I think it's important to know in that first study that we're talking about teens who wanted it and weren't able to get it. Because not all teens do want it, but those who are clinically depressed and do want it, it's a huge reduction in their distress to be able to access it. That research tells us that. And then our clinic is now just past 35,000 sessions of care. So we have a lot of cases that we can look at and say, here's what our trends are, here's what's going on here. And yes, what we see about distress, identity distress, teens with gender dysphoria are the most likely to stay home from school. They're the most likely to do what I call cocooning. That is, they don't play hooky, as we used to call it, and then go out with their friends. That used to be what people did when they left school, is they would do something with their friends, go out and have a good time instead of going to school. What we find in the distressed gender dysphoria population is they just stay home. They stay home in their rooms. If they interact at all, it's on some kind of social media or some kind of video game streaming, some kind of absorption of the digital social world. And their families hardly ever see them. They wonder if they shower. They wonder if they've gone to sleep or get up. They just don't see them. This is the kind of distress we see in gender dysphoric children. And then if the outside world is saying, we don't like you, give a bunch of reasons, then those young people feel thwarted belongingness, perceived burdensomeness, and the suicidality begins. What's going on in their mind? The passive suicidality begins. Then we just hope and plan for no access to means and no sense of, I'm not afraid to try it, because the wish and the attempt grows in that population. So we are, as you're saying, Natasha, we're talking about significant distress. I cannot interact with the world with this body. It's not a tool. It doesn't work for me, is what they're telling us. These are the ones that are most likely to consider hormone therapy.
And what do we know about the rates of both attempted and completed suicide amongst our trans teens?
It's huge. What I mean by that is almost all studies that talk about trans and non-binary people, as opposed to GLB, gay, lesbian, bisexual people, note and observe that the gender dysphoric, genderqueer experience lends itself to significantly more ideation. What we understand about this is it's not about the disconnect itself, it's about the social response. That when people are not accepting of who you are, the thwarted belonging and the perceived burdensomeness that we know are associated with increased ideation explodes. And that's where it comes from. People whose disconnect between body and mind are accepted and who are allowed to interact, who are, they have normal levels of depression and anxiety. It's how people respond to them socially. So when legislators come in and say, oh, you are not, we're going to let people without gender dysphoria make decisions about their bodies. We're not going to let you because you have gender dysphoria. Once again, that increases the thwarted belongingness and the perceived burdensomeness. Now my family has to go out of state to access something for me. Now my family has to risk financial stuff because mom and dad have to take a couple of days off work, and the rest, I am a burden to my family. So all of a sudden we have even more, and this is, as one of my colleagues put it, who does not share many of my views about this, it's at best unproven that these clients are experiencing more distress after the legislation. I say, okay, well, come take a look at 250 clients in my clinic and ask them about their experience and take a look at the notes about what's going on with them. Absolutely distress, withdrawal, difficulties, internal depression, anxiety. It's not because they've suddenly had something happen internally, because the external world has made belonging and burdensomeness more difficult.
And that's not even to mention all the kids who are not in your clinic, who are in homes. I mean, we live in a fairly kind of conservative state, as many of these states where these legislations are going forth, where parents are influenced by these decisions, where the parents have conservative views themselves, religious views themselves, and have a lot of these discriminatory ideas, probably think they're doing best by their children. I'm not, they love their children. Kids are not even coming out to their parents, are not feeling like they can even, have a discussion with their parents. Are a lot of times parents are saying things in front of their children, or, making comments about the news, or making comments about how they vote, or making comments about gender, politics. And so, if your clients are finding this distressful because their affirming parents who are bringing them to your clinic are now having more burden. I can't imagine the kids who can't even come out and, you know, to their families now finding that it's even that much harder in the states that are passing these kinds of legislation. So
Can I say something about that?
yes.
If your child can't even discuss their feelings with you, they are more likely to solidify an identity early. And then when they come out, push it at you so that they are not at risk, rather than just discussing their questions with you. Hey, sometimes I feel like this, sometimes I feel like that, and examining their own fluidity. If you have described this so well, Natasha. So many people I talk to say, I could never tell my parents, could never. And I think your parents might actually care about this. No, I've already heard what they say to others. I couldn't stand for my parent to look at me that way, the way they talk about other people. Can't stand that. So I will never tell my parents. When I turn 18, I will move to Europe and they will never hear from me again. I think your parent would rather have a relationship with you. I'm not going to do it. Yep, that's what you're talking about.
Yeah, no, it's very serious. Another thing I want to hit on really quickly, sports. This is a big one, right? This is a big thing that's coming up, and it's also coming up in a lot of the legislations. What kinds of bodies can play what kinds of sports?
Mm-hmm.
Do you want to share anything about that? And is that something you feel equipped to talk about?
Well, I have my own dream about this, which is that instead of it being male and female sports, we do what they do in boxing. They have arbitrary categories, but they're like featherweight, medium weight, heavyweight. That they've decided what's important in boxing as far as making decisions about who competes. There's such a wide spectrum. We start from male to female, or masculine to feminine, or whatever. I would like for there to be some categories of if you're like this or you're like this. We've decided these are the important characteristics that mean these people can compete. And instead of what's on your birth certificate, we want to know what's this about your body, so that we have you compete with people who are like you. That's my wish in the long run. But here's what I think about high school sports, where I don't think we should be talking about what's in people's bodies or what they look like or what they've got. I don't think that's the high school is about teamwork, including everyone, sportsmanship, how you, what happens when you win, what happens when you lose. If it's about who our best champions are and who should be competing, and my person is better than your person, and being rabid about that, then we've lost why we brought sports into high schools in the first place, which is about everybody should be learning, everybody should be playing, and let's figure out how to be inclusive. So that those principles, the two that I just sort of described, they influence how I feel about the sports bans, which of course I think are terrifically misguided.
Yeah, well, having had 3 male children who identify as male in the high school sporting culture, I can tell you that is not what it is like at all. I
Just
do
why we're
not
having
think,
the trouble we are.
I do not think that those are the American values at all. I am constantly in pain watching how many, we're ahead by 20 points and we're still not putting in, the second tier, kids. It drives me crazy. And then, and then all these, ideas that we as parents, should not be, giving input, which at some level I understand, because of course there's the parents who are super upset if their kids don't play at all. And I get it, but or that my kid will be, punished if I give the coach any input. It's very, very, very difficult. I guess we could do a whole nother podcast on American sports culture and how unhealthy it is. but yeah, it's very unhealthy, and I think very competitive and has its own issues. I think that when we have teens that come in with mental health issues who are on team sports, we usually have a lot of issues there as well as therapists, right? So that include not only parents, but coaches and school culture. So that, yeah, I think it's a much broader issue than gender, right? And I think you see the fear there of what it means to have a body that might compete in a way that we're not used to. It also ignores kind of like what, to kind of bring it full circle, intersex kids with chromosomal, issues. I think sometimes we have these, kind of athletes who really excel in ways that you don't expect. And we never look at kind of intersex potential, possibilities there. So those things have been around forever anyway. And then in the larger majority, it usually doesn't make much of a difference anyway, because most kids are pretty average athletes. Anyway, so it's interesting issue that seems to be drawing a lot of attention for, again, a small population that might be affected from a very, very competitive perspective. What am I missing from this conversation that you'd like to bring up? Are there myths that I'm not thinking about, kind of the top fears or top things that you're like, oh, this drives me crazy every time I hear it, because it's just such a misinformed or ignorant kind of stance. And I hope people don't get offended by my word ignorant. I mean, ignorant just means you don't know what you don't know.
Right. You have to start from somewhere. And I'm glad that people who don't know will ask questions. I'm only bothered when people who don't know become certain and rigid without asking the question, without finding out what's really going on, starting from an assumption that this is what should go on and this is what makes a better society. So let's not actually pay attention to what's happening. That bothers me. Okay, here's a myth I'd like to address. Body dysmorphia, which is what we experience when an anorexic person says, I'm fat. This feels like, wait a minute. Is that similar to gender dysphoria, where a person with a vagina says, I'm meant to be a man? Why are these different? I hear this question quite a bit. When we know, if we take a person who has anorexia and we say, oh, let's explore this. Maybe you really are fat. Let's go with that and see what that does for you. We know that that's going to be life-threatening, because to support someone who believes they are fat when they are actually medically emaciated is not going to have a good outcome. So people say, shouldn't we apply the same treatment then to people with gender dysphoria? Your body actually has a vagina. So shouldn't we help you actually do more women things, be more woman-like, get into that and recognize you really are a woman. You really do have breasts. You really are. Nature intended you to be a pregnant person at some point and perpetuate the species. Isn't that helpful? Well, here's what we know. When you take that treatment to a person with gender dysphoria, you actually create more distress. You create more suicidal ideation. You create more depression, anxiety. All of the pathological, internal pathologizing things occur to you then, and your life is more at risk. So if we take an outcome-based approach, we say, no, not a good treatment. Just because it looks to you as an outside observer like body dysmorphia and gender dysphoria are the same thing, doesn't mean the treatments are the same. One is actually poison for the person that the other one is helpful for. We have to look at outcomes, not just to do these things look like. Huge myth. I hear a lot.
Thank you. That's a super important distinction. The other thing I wanted you to just kind of talk about just briefly again, because you mentioned it slightly, is this closure of the England clinic, because I do think that there are some misconceptions about that.
Yes, the official word is that they are opening regional clinics, when Tavistock opened, there were not very many people who needed this care and treatment, but they did need it. When a clinic is absolutely overrun with people, it cannot function at all. It may begin to take on some people who are not well trained. It may begin to have some protocols that work for some people that don't work for others, but they don't even get a chance to actually step back and say, what works best? What do we need to do here? So with the closure of Tavistock, England is now opening regional clinics with a new awareness of what it is that's going on. They have stopped planning for gender care. Medical treatment for gender care is evidence-based. So we just need to do a good job at it and find out what is happening with detransitioners, what's happening with people who said, my care happened too quickly, too fast. That needs to help inform the care that we're offering. So gender affirming care will continue to happen in the future, and it will get better and better as we get better and better at looking at research. But to stop that care in order to wait for the research is the worst kind of insult. It's as though straight people get to say, you don't get to make a decision about your care. We don't trust you. I do not know why straight cisgender people are allowed to make decisions.
Yeah, and if you don't
about
mind,
transgender, non-binary people.
if you don't mind spending like another 5 minutes, I know we're over time. Just there's
Oh,
so much I could like
so much
pick
more
your brain on. But yeah, let's spend a little bit of time on this kind of like detransition regret, right? Because that's another thing. It's like, well, some people regret it. So are we being careful enough to make sure that people don't have these regrets later on in their life, especially if you're doing something that's it's irrevocable, you can't change it. I think the research shows that maybe it's less than 1% of people who have some, and now let's talk more about adults, because like you mentioned, we do not do surgeries and kind of some of these more unchangeable
Are
type
not
of things.
routine or
Right.
prevalent,
Yeah.
correct?
Let's talk about adult things.
Because even some adults do have some regrets. The primary regrets, however, are not about the body. They are about, it did not result in people actually seeing me as who I am. And that interface that's so important that we change our computer picture because we don't like it. That interface of who we are with the public, it is day to day to day for a person who is longing for other people to see who they are on the inside. To never have that, we don't really understand that. People talk about bad hair days that make people not treat them well. Are you kidding? Talk about a bad identity life that people will never actually, to hear the longing in a person who says, I had a dream that people treated me like who I am. Then I woke up and I have to have this again. This impacts people deeply. And this is one of the major reasons people regret the surgery they had, is because it does not result in the acceptance they longed.
Yeah,
But
right.
that's about society, not about the body.
Right. And I think too that, like, to your point, it's not that we shouldn't look at those, like I think you called them outliers before we were talking, and it's always important to look at outliers in any form of treatment and listen and learn and make treatments better and make options better. At the same time, why stop what's working for 98% of people for what may or may not be working for less than 1% of people? It also kind of ignores medical treatment for the rest of us. Like, I know there are definitely people who regret chemotherapy. There are people who regret hip replacements. There are people who regret plastic surgeries. There are people who, but yet we don't legislate in this kind of frantic, frenzied way. Well, that people don't have the insights or the the well-being or the mental health in order to make these decisions for themselves, right? We don't treat people in these ways to make decisions for themselves, even though we have research to support that in almost any medical intervention, there will be a certain segment of the population that will have regret. And even with decisions that have to do with lots of pediatric types of interventions, right? There's tons of decisions we're making for kids and decisions about
That can be permanent.
diabetes and surgeries and, you know, whether or not, I mean, it's very complex, right? You have to make decisions all the time that are difficult, you know, whether or not, you know, we're having to make our decision for our 5-year-old that we don't know, you know, do we want to put in even cochlear implants, or do we want to, you know, teach sign language? And it's very, very complex, and they're very complex decisions to make. But then we don't go into this frenzied state and legislate everything and make things, you know, just not even an option for parents and medical professionals to make in their circumstances for their own decisions. And this is kind of one of those things that, yes, the ethics are complex, personal experiences are complex, but why are we taking choice away from parents and medical professionals and mental health professionals? That to me is what is so infuriating.
Mind-boggling. Yes. I have heard people compare it to the conversion therapy ban, what we called conversion therapy bans. And I like to clarify that good mental health and medical health decisions can still, even with conversion therapy bans, treatment that did not constrict healthy treatment, evidence-based treatment can still happen. You can still help support a mixed orientation marriage. We can still help support people who want to participate or maintain or move toward a covenant life, for example. We're not restricted in that. But now, evidence-based treatment for clients with gender dysphoria have been severely curtailed and restricted, and their mental health is decreasing. Their positive mental health symptoms are decreasing because of what has happened. So I don't consider them similar at all.
Yeah, we restricted a type of therapy that actually decreased mental health, increased suicidality, and was religiously based due to, you know, I mean, yeah, don't get me started on that one. It's just like,
You agree,
and
right?
has caused people like thousands of dollars of mental health treatment to try to recover from these conversion therapies that their parents put them in when they were teens, right?
Yeah. And you and I see those clients every day. Mm-hmm.
Yeah, every day. Okay, as I guess and maybe, you know, I'm going to try to bring on some people on the podcast that maybe have more of a medical background than both of us do. But maybe the last little point is this kind of, we don't have longitudinal studies to know what kinds of effects hormone blockers or puberty blockers, you know, you mentioned the bone density kind of argument. So why would we take risks that might affect, you know, long-term health issues with our teens? Is there anything you want to say about that?
Yes, and that is that parents and teens can make long-term decisions that actually improve their lives. And although we don't have longitudinal, we do have retrospective studies that are compelling, which are that adults who did not have access to hormone therapy when they were teens have harder lives than those who did have access. They have more problems in their lives, academically, financially, socially, psychotherapeutically. Psychologically, they have more challenges in their lives when they did not have access. That should help us take a look at, then why would we deprive teens and parents of these decisions if we know their lives are likely to be harder and have more of these obstacles in them? That we are sentencing people to this should impact us as people who do not have these problems fact that we're sentencing other people to them should make us pause.
Yes, I would agree with this. And there's quite a bit of research showing that for any mental health condition, we now know that if you are suffering from depression, from anxiety, PTSD, these things actually shorten your lifespan by like as much as a decade. And of course, with the primary issue being, of course, the suicidal risk, which is, when I talked with a colleague of mine, it's like, well, having lowered bone density issues, because she was a trans colleague, and she said, I knew I was taking a risk with bone density, but I would rather have bone density issues than continue to have the suicidality risks I had, so that was a very intentional decision I made. And again, I don't know that people really understand that the suicidal risk is sevenfold for transgender folks. So that's incredibly risky, higher than bipolar disorder, higher than many of the issues that we have. So,
and again, not because they're just less psychologically sound people. It's because of the treatment and the fact that they're treated as adolescents no matter their age. Yeah.
Right. Well, Lisa, Dr. Hansen, this has been a phenomenal interview. Thank you so much. I think you've really given us a lot to think about. I hope people really will take to heart so many of the points that you've talked about. I quoted in kind of the introduction to this on kind of the write-up is that, it's Maya Angelou that said, when we know better, we do better. I'm trying to keep faith in that statement because I have seen all of your points shared at legislative spaces where people share this research, where people share this data. I have seen all of this being shared, in religious spaces with religious leaders. I've seen this information being shared with parents or in school councils. And I oftentimes do not see people be able to shift or move their either political views or their ability. They can't shift it doesn't seem like they have the ability to shift. And that's very disheartening to me when it comes to what we see on the ground, which is there is such pain and there's blood here, there's blood on the ground. And I think sometimes we as mental health professionals, we're taught to be poised and we're taught to be professional in how we talk, and we talk about these things so pleasantly and kindly and respectfully. And I just get so rageful and angry when I see the results at our doors and on our couches and in our crisis centers. And I just, and then I see all this vitriol and the politicians and the news people using all this provocative language. And I'm like, I don't know if we as clinicians need to get just more vibrant in the way we're talking about this stuff, because I can't take it. I'm just so upset at what is happening. I don't know that I sometimes recognize my country anymore. I try to remember, like you said, like we are in cyclical stages, like kind of like your dad being shocked that women wear pants, and now we all wear pants like it's no big deal. So I'm trying to remember that these things go through cyclical stages, and hopefully, like Martin Luther King said, the arc of justice is long and wide. We hopefully will see
it continues to bend, and we see that in our children.
Yes,
we see that in our children's attitudes. That's what gives me hope.
Yes, it's just dramatically tragic. It's all the unnecessary tragedy of all the bodies that we leave in the wake of this.
Yes, and the potential that we waste.
Yes.
Of who could be shoulder to shoulder and who could be making this world a better place. And the people who have ideas about that, who are relegated to the outer circles. Yeah, that is a tragedy.
Thank you for all the work you do. Thank you for all the work all your clinicians do. Please consider a donation to Flourish. Please consider, if you're not in Utah, or please consider a donation to the community centers and the clinics who are doing nonprofit work in your communities. please figure out who they are. Please look them up. Please, there's Pride events that are coming up. Pride Month is coming up.
Cougar Pride today in Provo.
That's right. Cougar Pride is today in Provo.
And about Flourish, every donation goes to subsidized therapy for a client. All of our overhead is covered by insurance. So please know that's where your donations go.
That's right. So, and I'll make sure to link all of that in all of our, at the website, the podcast website, and all of our media. So thank you, Dr. Hansen, and I wish you the very best.
Thank you, Natasha.
Take care.
Bye.
Thank you for listening to this episode of the Natasha Helfer Podcast. To help keep this podcast going, please consider donating at natashahelfer.com and share this episode. You can find Natasha on Facebook at Natasha Helfer, LCMFT, CSTS, and at Natasha Helfer MFT on Instagram and TikTok. You can find all her cool resources at natashahelfer.com. The intro and outro music for this episode is by Otter Creek. This podcast was edited by Ashley Puccini.
There is a place where time slows to nature's pace, and there is space there to find yourself in her embrace. Some places should be left alone. No tishki say the no. So we can always go to the homeland of the heart. 10,000 years of our human history etched on her canyon walls, alongside Earth's mysteries. Some places should be left alone. No tishki shade no. So we can always go to the homeland of the heart, to the homeland of the heart. Deep in our cities, we sleep without her stars, yet still her presence sustains us from afar. Some places should be left alone. No tishki shade no. So we can always go to the homeland of the heart, to the homeland of the heart, to the homeland.